Hey everybody, welcome to the channel. My name is Reed and I really enjoy going over EKGs. If you enjoy these, please feel free to subscribe and give me any feedback so that I can make this better for you all. So let's get started. So the first thing I like to do is I just like to get a gist of what's going on with the EKG, and I do that by going down here to lead 2, and I might look at just a general idea of what is my rate and rhythm. I see I've got these narrow complex QRSs here. They're kind of small in amplitude, but they're narrow, they're occurring regularly. You can see that, interestingly, my P's are larger in amplitude than my QRS's in lead 2, which is okay. That all has to do with just the QRS axis. But I'm kind of marching through it, a narrow complex QRS with a regular rhythm. This one seems to occur a little early if I measure my R to R interval. For these two beats, I would expect this beat to occur here, but it seems to occur a little early, so maybe early. I see that also occurs here with this beat occurring a little early. If I measure my R to R interval, I would expect to see a beat maybe here, so maybe a couple early beats. And let's go through and see, what are the characteristics of this EKG now that we've got an idea of what's going on. So we've got a narrow complex QRS. My rate is roughly, if we go from, say, this QRS that lands on a solid line, 300, 150, 100, 75, 60. So somewhere in between 60 and 75, I would say perhaps 70 beats per minute. That's reassuring. Let's take a look and see, what is the atria doing? Is the atria driving this rhythm? I look up here in lead 1. I see I've got upright P waves in lead 1. In an AVF, I've got these upright P waves. And so I've got P waves that are going down and to the left, which means that is coming from my sinus nodes. These are sinus P's, sinus P waves. That's reassuring. That would make sense. Sinus node typically beats at 60 to 100 beats per minute, so that fits the clinical picture. Well, next in the conduction system is going to be our AV node. And our AV node is evaluated best by looking at the PR interval. So one good way I like to evaluate the PR interval is I'll find a QRS that starts right on this solid line. This one starts a little before the solid line. If you notice, it starts maybe right there. So it starts on that little line just before the solid line, and our P wave starts just about 200 milliseconds. So this is right the maximum that I would like to see my my PR interval be. So this is still a normal PR interval, but it's right at the borderline of a first degree AV block. I notice that all of my P's conduct to QRS's. So it happens every time, so that's reassuring that my AV node is doing its job. When I take a look at my QRS's, I did notice that they are narrow, and I noticed that my QRS's are upright in lead 1, and they're downward going in AVF. So that tells me that my QRS axis is going up and to the left, right? Because it's going away from AVF, but towards lead 1. So my QRS is going up and to the left. And so this would be somewhere kind of a left axis shift. And so we've got a little bit of a left axis shift with a narrow complex QRS. Well, I think, what are some common causes of that? And what I could look for is maybe, is there ventricular hypertrophy? And so I come over here and I see I do have some deeper S waves in V2. If I calculate the amplitude of these S waves in V2, it would be from roughly there to there. So that would be, say, 5, 10, 15, 20, maybe 21 millimeter S wave in V2. And if I add that to my R wave in V6, which is roughly to here, we've got 5, 10, 12 millimeters. So 21 plus 12, that is going to be 33 millimeters. So not quite left ventricular hypertrophy, but it's close. So we do have a little bit of a left axis in this EKG, and that's okay. So now what do we look for? Well, when I look for left ventricular hypertrophy, sometimes I do just like to, I see that it's borderline, right? We know that the EKG is not the most sensitive for left ventricular hypertrophy. We know that if we want to determine if the ventricles are hypertrophied, we look at imaging like echo, where we can visualize the ventricles. But in this case, I do notice that it's borderline, so I might as well just quickly evaluate what is my left atria looking like. If I've got borderline electrocardiographic criteria for LVH, let's look for a left atrial abnormality, because we know that if the left ventricle is in any way compromised chronically, we're going to have increased strain on my left atria. So understanding the physiology of the heart, I can also look for left atrial enlargement. Well, the best way to look for left atrial enlargement is to go to V1. And in V1, I do see these nice large negative deflections in my P's. And because my negative deflection appears to be larger, just about the size of one small box by one small box, or 1 millimeter by 1 millimeter in area, I would say that this meets criteria for left atrial abnormality. Otherwise, you could call left atrial enlargement. It's the same thing. And so that's just clinically kind of what I like to go through. So this is electrocardiographic evidence of that. And so we look now at our ST and our T waves for any ischemia or old prior infarctions throughout all of my leads. And I just scan through and I don't see any. I might see some non-specific here T wave inversions in the lateral leads. And if there is some borderline LVH, you can sometimes see that in those leads that capture that. That would be a strain type of ST T wave change. So that could be common because we are borderline LVH here. And so before I finish up with this rhythm, let's take a look at these premature beats. So if I zoom in on my premature beats, we said that this one right here, if we look at our QRS, we have a narrow QRS. And the QRS is the same morphology as the previous QRSs. But if you look in front of it, our P wave has a different morphology. Usually our P waves, if you look here, are upright and large P waves. This one is negative and downward. And so we have a premature beat with a P wave that is different morphology that conducts normally to a normal QRS. So this is a premature atrial contraction. And if we look at the others that we said are premature, here we see the same thing. We see this negative P wave that conducts to a QRS that is different from our typical P waves. So this is a PAC. So interestingly, the morphology of all these PACs, PAC, are the same. And so these are actually all likely coming from the same spot within the atria that is causing that abnormal depolarization. So what is our final read on this EKG? We've got a sinus rhythm, left atrial abnormality, and PACs. So I hope this rhythm helps for your learning, and have a great day.